brain tumors. So we'll start out with Eris Spirollari. He is a fourth-year medical student at New York Medical College. He did his undergrad at Rutgers, where he graduated with honors in cell biology and neuroscience. He's done some basic science work. He was working in Dr. Ping Zhi's lab for 1 year to study the regulatory immune system role of the TRAF3 cytoplasmic adapter protein on different subsets of immune cells. And he's also collaborated with neurosurgery at New York Medical College on numerous clinical outcomes research projects, looking specifically at therapeutic targets of medulloblastoma, glioblastoma stem cells with Dr. Meena Janwar Uniyal. And outside of school and the hospital, his hobbies include weightlifting, spending time with his family, playing basketball, and PC computer building. Thanks, and take it away, Eris.
Okay, thank you for that very kind introduction, Dr. Kellner. I'm just going to share my screen now. Okay. And okay, so hi everyone, I'm Eris, and today I'd like to present a project I worked on most recently under the guidance of Dr. Fawaz Al-Mufti in collaboration with the Westchester Medical Center, Department of Neurosurgery. I'll be discussing the topic of early tracheostomy in patients undergoing mechanical thrombectomy for acute ischemic stroke. So according to the American Heart Association, acute ischemic stroke is the fifth leading cause of death in the United States, with an incidence of 236 cases per 100,000 population. And in addition to that, stroke-related healthcare costs are reported to exceed nearly $70 billion every year in the US alone. Now, in terms of the actual standard of care for these patients with large vessel occlusion, endovascular mechanical thrombectomy has been shown in several landmark stroke trials over the last decade to have superior outcomes for eligible patients over medical management alone. However, for stroke in general, respiratory compromise is a known common complication, which is often multifactorial due to disturbance of central rhythm generation, interruption of descending respiratory pathways, leading to a reduced respiratory drive, bulbar weakness causing aspiration, and increasing ICP, leading to overactive sympathetic discharge and a resultant neurogenic pulmonary edema. So for many of these reasons, mechanical ventilation is often necessary in stroke patients to address airway failure, such as obstruction and secretion clearance, and optimize gas exchange in preventing vasoconstriction and the progression of cerebral edema. So overall prognosis, however, for stroke patients requiring mechanical ventilation is poor, with mortality ranging between 40 and 80%. Thus, the optimization of airway management is especially crucial for improving outcomes in these critical patients. As a result, these patients on prolonged mechanical ventilation often require tracheostomy, and this is to really facilitate breathing as well as long-term airway protection through mechanisms including the benefits of a short tracheal cannula compared to an oral tracheal tube, leading to less airway dead space and reduced work of breathing, as well as the avoidance of oropharyngeal and laryngeal lesions, leading to improved patient comfort. And in addition to these benefits, studies have also found recently that there's been a reduced need for analgesia as well as sedation among tracheostomy patients with earlier mobilization and transfer to rehab. However, the complications to be aware of, as with any procedure, there is potential risk for damage to nearby organs, bleeding, infection, and pneumothorax, which are all known but less common complications that may result from tracheostomy. So despite these risks, it is widely agreed upon that tracheostomy should be performed as soon as the need becomes obvious. But how this need is determined still remains controversial, and the optimal timing of the procedure is unclear. And so in current clinical practice, the procedure is performed commonly 1 or 2 weeks after intubation, and this usually occurs after extubation attempts have already failed. Specifically for some reference of a national average and one retrospective national database study we found by Chatterjee et al., they reported an average post-stroke timing for tracheostomy of 10.3 days after mechanical ventilation. Now, with this controversy of timing in mind, our current project builds upon prior RCTs, most notable of which being the SET.1 trial in 2013 and SET.2 in 2022. SET.1 was a study out of the University of Heidelberg in Germany, where post-stroke patients who were estimated to be on prolonged mechanical ventilation for at least 2 weeks were randomized to either early tracheostomy, which was less than 4 days from intubation, or to the standard timing group, which was between 7 and 14 days. Now, although in this study, ICU length of stay was not significantly different between the two groups, they did find that the use of sedation, duration of mechanical ventilation, and 6-month mortality were significantly lower in the early tracheostomy group. And similarly, in set point 2 in 2022, which now expanded as a multi-center RCT in both Germany and the United States, stroke patients expected to be on prolonged mechanical ventilation received early tracheostomy less than or equal to 5 days from intubation. This study, however, now showed no significant difference in their primary outcome measure, which was functional improvement as measured by the modified Rankin score at 6 months. And additionally, this time there was also no difference in mortality between two groups as compared to set point 1, which did show a positive benefit for the early group. So in both of these study samples, we see really a mixed or even minimal benefit for early intervention. However, it is important to note that there was also no evidence of inferiority compared to standard timing here. So given these findings in our current study, we utilized the highly validated national patient sample to further assess the impact of tracheostomy timing and acute ischemic stroke patients' outcomes in a large real-world sample. So for additional context of the NIS as a data source, it is the largest all-payer healthcare database in the United States, representing 20% of all inpatient admissions every single year. These inpatient records include a variety of information such as demographics, characteristics, diagnoses, procedures, and discharge disposition for all documented patients. Regarding our patient selection, we utilized NIS from years 2016 to 2019 and queried for patients with acute ischemic stroke using ICD-10 diagnostic codes. And from this population, we then used ICD-10 procedural codes to first select for patients who underwent mechanical thrombectomy, and then from this population subset, likewise identified patients who underwent tracheostomy. And now with regard to how we define our data characteristics for analysis, we chose an early tracheostomy cutoff placed before the 8th day of hospitalization, which in our case was less than or equal to the 25th percentile in our selected patient population. And this cutoff also coincides with several of the articles in the literature describing day 7 as an early cutoff commonly used for tracheostomy. Then for our other study variables, a hospital length of stay longer than the median of our specific population was defined as prolonged length of stay, which in this case was greater than 21 days of hospitalization. And furthermore, routine discharge was a variable we defined as discharge to home or self-care. Then in terms of outcome measures, our primary outcomes were inpatient death, complications, and length of stay, while our secondary outcomes included discharge disposition as well as total hospital charges. Now, in terms of our actual results, from 2016 to 2019, we had 132,210 patients with acute ischemic stroke who underwent mechanical thrombectomy identified from the NIS. Of these patients, 3,580 underwent tracheostomy. Then of these tracheostomy patients, 915 had received the procedure before day 8 of hospital stay. Looking more at the baseline demographics comorbidities, we found that among acute ischemic stroke patients who received mechanical thrombectomy, those who underwent tracheostomy were more likely to be younger, have greater comorbidities, have a greater stroke severity score, and they were also more likely to have had a posterior circulation stroke compared to those that did not receive tracheostomy. Now of the acute ischemic stroke mechanical thrombectomy patients who had undergone tracheostomy during their hospital stay, early trach was associated with a shorter total hospital stay, fewer total hospital charges, and lower rates of complications such as sepsis, DVT, AKI, aspiration pneumonitis, and pneumonia. And finally, in a multivariate logistic regression, controlling for factors of stroke severity score, age, female gender, and comorbidities, we found that patients who had received early tracheostomy were independently associated with a reduced rate of prolonged length of stay greater than 21 days and a reduced rates of prolonged mechanical ventilation greater than 96 hours, as well as reduced complications of pneumonia, sepsis, and acute kidney injury. Of note, however, there was also no significant difference in mortality found in the adjusted early tracheostomy group. So in conclusion, we found that early tracheostomy was associated with reduced total hospital charges, decreased length of stay, reduced rates of mechanical ventilation, and reduced rates of pneumonia, sepsis, and AKI. Our findings add to the current body of literature illustrating the benefits of early tracheostomy using a national representative sample of AIS patients. And these results really suggest that early tracheostomy may further play a role in facilitating discharge and recovery. So we believe that further prospective validation of these retrospective database findings, as well as study of placement and timing of tracheostomy, is warranted to optimize post-stroke patient outcomes, which often includes respiratory compromise. As for the limitations of this study, inherent into any database research, retrospective database research, that is, we have limited availability of outcome measures, such as the modified Rankin score, which is not possible to calculate within the NIS, even though it is a useful tool to study post-stroke outcomes and compare to past studies. Similarly, with a non-randomized retrospective database analysis, all of our patient information is extracted using ICD-10 codes, which can be heterogeneous throughout the nation with an inherent risk for incorrect coding. Although we did seek to mitigate any errors due to the shift from ICD-9 to ICD-10 codes by focusing on the years 2016 to 2019 only. Furthermore, in terms of limitations, the NIS only captures the duration of the hospital stay and lacks long-term patient outcome data. And then finally, clinicians' occupations, practice patterns, and clinical experience is not available for evaluation, which may always have an effect to introduce bias to our findings. But although several of these study limitations exist, we believe that our large cohort size and utilization of national data very much highlights the broad applicability of our findings as compared to smaller trials conducted in the past. And to the best of our knowledge, this study also represents the first evaluation of tracheostomy timing in acute ischemic stroke mechanical thrombectomy patients on a national scale. These are our references. And I'm also happy to share that as of 2 months ago, this paper was also recently published in the Journal of Critical Care. So thank you for listening to my presentation. I'd like to acknowledge Dr. Amufti, Dr. Gandhi, and all of my mentors at Westchester Medical Center that guided me, made it possible to complete this project. And also a very special thanks to all the residents, faculty, and staff here at Mount Sinai for being so welcoming, getting us involved, teaching, and helping make this month really one of my most memorable experiences in medical school. Thank you very much, and I'm happy to take any questions.
Thank you very much, Eris. Great job. So the prospective data in set point
Yes.
does not show a long-term benefit, but then the NIS did suggest there's a earlier discharge with tracheostomy.
Yes.
Yeah. So there's some discrepancy there. How do you explain that?
Yeah, there's a few reasons why that might be. One being that set point one, first of all, only took place in Germany, had a much smaller sample size. There may be differences in access to care there and possibly access to rehab compared to the national sample we have in the NIS here in our study. And also the cutoff they chose for early tracheostomy was 3 days, which we believe may have been a little early compared to our study, which we selected as less than 8 days. Maybe the patients they selected to be in the early tracheostomy group possibly did not need tracheostomy and may have not benefited as much as patients that could have actually used the tracheostomy. And similarly in set point 2, they had a cutoff of 4 days. So maybe they were too much on one end of that extreme and could have benefited from using a later cutoff that we selected. And other than that, we believe that our sample size and different geographic variation possibly provides a better representative sample of the benefits of early trach in a large sample.
Great points. Any comments from our intensivists?
Yeah, hi, this is Greg Capinos.
Yeah.
To me, it's not too much of a timing issue, as you brought up, 4 days might have been, or 3 days might have been a little bit too early indeed, and maybe we have an entire week. What is beautiful in your, what is really great that you're bringing forward is a better selection of which days, which patients, need to be trached within that first week. So the posterior circulation stroke, or actually using a score that tells you that they will have a bulbar weakness, and better selecting our patients for this early trach is the money that we need to invest in, rather than focusing on the ideal timing. It's better the selection of the patients will have that will have problems with an extubation.
Yeah, that's a great point. Set.2 actually developed their own prognostication score to evaluate for patients that might benefit more from the early trach. And after they had implemented that, actually, the outcomes were even less showed even less benefit for early trach groups. So it's interesting to see that. I think maybe further study, as you suggest, should focus more on developing or finding characteristics for patients that may benefit more from early intervention than not.
Any comments from the residents?
Trevor, you got your hand up.
Hey, yes, thank you, Eris. Great presentation. Just had a couple of questions about how you all were looking at some of the variables.
Of course.
How permissive were you with the tracheostomy procedure coding? So in the database, it can either be listed as procedure 1. Some people argue that those are the procedures that should be included only, or you can go all the way out to whatever number of procedure you have listed. Usually there's anywhere from 25 to 30 if you're looking at 2016 on. So the question would be just how permissive were you guys with that? The other question I would have is, did you see similar trends when you weren't accounting for the NIH stroke score? That's a variable that's typically only included in about 20% of the total stroke patients 2016 on. So, it's something that just isn't coded for that routinely, although it is very helpful when it is. So I just wanted to know, did you see similar trends when you weren't accounting for that and your multivariable analysis?
That's a great question. Regarding your first point, we were permissive, like you said, for accounting for all procedural codes, not just for the primary procedure performed at admission, because we wanted to develop the largest sample possible. And regarding your second point, the national NIHSS score was used in our multivariate analysis, but I don't think we performed the multivariate without that. I know that in our cross-tabulation analysis, we did see similar results. So I think that may answer your question here, because like you mentioned, not all patients had an NIHSS score.
Yeah. How did those patients, so when you were looking at,
Yeah.
were you patients that only had NIHSS, were those patients excluded or?
No, yeah, that's a good point. No, we did not exclude patients that did not have the NIHSS score. That was not part of our selection, actually. This is just for the patients that did have the NIHSS score, this data was included. And there was a significant difference for the patients that did and did not receive tracheostomy in this case.
Great, nice work.
Of course, thank you.
All right, thank you, Eris. If you can stop sharing,
Yep.
we'll move on to